some build institutions, and some quietly shape the future of an entire specialty. Today, I have the honor of speaking to someone who has done all three. Dr. Nalini Kaul Mahajan. She is not just a pioneer in IVF and fertility preservation in India, she's a teacher, a thought leader, and a name that commands deep respect across generations of reproductive medicine. She has over 3 decades of experience and has trained internationally, led national and global fertility bodies, and has helped thousands of families experience parenthood often after years of loss and uncertainty. Ma'am, welcome to the podcast.
Thank you so much for having me here.
I'm glad you came, ma'am. So, ma'am, let me start. When someone looks at your CV today, it almost feels intimidating in the best way possible. And I would like to iterate क्या क्या आपने achieve किया है. Gold medal for standing first in 10th board examination.
Oh my God. I think we can do away with all of that.
No, ma'am, it needs to be told. President's gold medal standing first in MBBS. Pfizer gold medal for best student in medicine. Saraswat Chandar silver medal, best candidate MBBS. Honors masters in ART. Best paper presentation 97, best paper presentation 99, best paper presentation.
I think we should
IFS
stop
2000.
it right there, please.
No, ma'am.
It just becomes embarrassing.
First to perform ovarian tissue activation in India. Established Mother and Child Hospital 95, one of the first IVF centers in Delhi. Ma'am, I couldn't even mug all this up. Established state-of-the-art IVF centers in Delhi NCR. Founded Fertility Preservation Society 2014. Published FPSI recommendations for fertility preservation in Indian patients. मैम ये सारी गाइडलाइंस रेफर करते हुए मैं शायद अपनी रील्स बनाती हूँ. आपने इतना सब कुछ कैसे कर लिया?
कुछ भी अकेले नहीं किया जाता है. There's always a team. There are always people who are there to help you, to guide you, to be there with you. And you always, whatever you achieve, there's always a teamwork there.
Sure, ma'am. Ma'am, what inspired you to go towards obstetrics and gynecology? That too ART, infertility. That too, जब ये बहुत ही infancy stage में था, taboos associated थे इसके साथ. आपने कैसे? Why did you join this field?
Okay, so I was thinking about this question of yours, कि ops gynae क्यों? And the answer is so silly. In a sense, I found ops gynae very easy. Okay, very simple to understand and recreate answers just by using your logic and your understanding rather than mugging anything up. So I could relate very well, and then I thought perhaps this is the subject I should go to because I find it so comfortable doing this subject. So that's how ops and gynae. And so what happens, I think when you are routinely, जब आप एक ही काम करते जाते हो वही hysterectomy कर ली, deliveries कर ली, after a while सब कुछ boredom sets in.
बिल्कुल.
You want to do something different. You want to challenge yourself. कि आप उतने ही के लिए थोड़ी सिर्फ पैदा हुए थे. कुछ और भी करना था आपको ज़िंदगी में. और एक दिन मैं देख रही थी, there was a program on, I think it was on BBC World or one of these things on IVF. It was the very first where they had just started
Discussing.
Steptoe and this one, Bob Edwards. And they showed the entire process of the embryo formation. They didn't show the pickup or anything, but they showed the embryo forming and dividing. And I mean, I was just sold. I was so fascinated that I said, no, this is something I have to do. And that was a time in India where nobody was doing anything. And, the very first few people amongst us who did even start off was around that time. And जैसे आजकल आपके पास everything is available. Your entire, if you want to read up something, you understand something, gain knowledge, it's all there at the click of a button. But for us, it wasn't so. We had to work really hard to even gain that knowledge and the insight. And how do you even go about trying to, get there, trying to perfect yourself or in the process, because at that time it was a very difficult process. It wasn't as simple as
It is now.
what it is today. So, but the seed had gotten sown, and once that idea is there, you can never get it out of your mind. Okay, and so slowly, I worked on it, and this was in 1992, 93. Nottingham came out with the first ever master's course in ART.
Wow,
it was the
ma'am.
first in the world that they came out with. And I applied. My children were already in school at that time. And it was a year's course. So you can imagine the dilemma of, on the one side, leaving your kids who were still school going, small. But on the other side, the thought of doing something, special, something different, was just
Ignited.
too exciting. I couldn't sort of not do it. And so I did go. And, and at that time, infertility के लिए there was nothing available. मतलब एक हमारे पास एक टैबलेट होती थी क्लोमिफेन की जो देते थे, उसके अलावा कुछ भी नहीं था. It was really sad when you dealt with all these patients that you had nothing to offer them. So this felt very exciting, that at least you'll be doing something better, something you'll have to offer them when they come to you. So I spent a year there. And let me tell you, it was so tough because you're out of touch with academics in the sense of learning and, preparing for exams and writing a thesis. So it was really tough in the initial few months, but then you sort of pick up and catch on, and it became a very, very exciting journey. I used to spend hours, nights in the lab alone by myself trying to do stuff. Whatever I was given in my dissertation, so I would sit there and do that. And through the cold of winter, it was like, in UK it gets dark at 3 p.m. towards winter. And in that, at 6 or 7, I would leave the lab, or at 8, and in that bitter cold and icy cold winds, I would walk back to my hostel. And but whatever it was, I think the inner excitement and thrill was so much that I never minded any of these things. And there was a lot of studying to do. I had to write my dissertation. It had to be cleared. We had the exam and the interview and whatever. And finally, I came back home. But the challenge didn't stop there.
Yes.
The challenge was, how do you start? Nothing was available here.
In India.
Everything had to be ordered in from outside. You even, like today, you just give, on a turnkey basis, you have somebody coming in, setting up your whole lab. But you had nobody. So on what you had, where you had worked, you took that picture and tried to recreate a lab and an IVF setup with that. And how the air pressures to be maintained, what is the air conditioning to be maintained, what is what the temperatures, how do you make your media, all of that. So it was very tough, but at the same time, when I look back on it, I don't remember a tough time. I just remember being excited all the time that I'm going to do this.
Ma'am, actually वो drive थी आप में to learn something new. That is why those challenges seemed easy. Ma'am, जब actually when I was sitting with my family, and I was going through all your achievements, I was like, मेरा भी छोटा बेबी है, तो I was like, मैम ने ये सब कैसे अचीव किया? And I could see there after doing your post graduation, there is a gap of 4-5, couple of years. 1979, I think you did your AR.
One year. No, I've completed my post graduation after I had my son. There was a gap of a year. I had done my first year of post-graduation, and then I was unwell, so there was a gap of a year, and then I rejoined and completed my post-graduation. That was the only gap.
Then ART?
No, ART was not a gap. I was working, my nursing home was running, and I took that 1 year to go and do it while somebody else was sort of working. So in that sense, it was not a gap. But yes, if you say that in terms of clinical practice, it was a gap because this was totally embryology. And the reason I took this up was because we had no embryologists here at all. And so, okay, the clinical part I may still learn, by reading or understanding. It wouldn't be so difficult. But what was going to happen on the embryology side? Because there was nobody. So that's the part you had to learn. So that's what it was.
So, ma'am, जब आप वापस आए, you must have had a lot of from the patient's end, social, professional, plus लोगों की क्या सोच है regarding infertility. That time it was not. अभी भी there is such a mental
There's a stigma.
blockage.
Yeah, there is, but nothing like what it was at that time.
How did you battle that in the beginning?
See, how do you battle it? You don't have to battle anything. You're offering a treatment. Okay, you're offering. The thing is counseling the patient that, okay, this is something new that you have heard, but this offers you hope. Unfortunately, at that time, IVF results were like 20%.
Bad.
So even though you offered hope, it wasn't some huge great hope, but then on the other side they had no hope. Tubal factor, male factor, infertility. So there was no hope there. So at least you could offer this. You had to counsel. Then very reluctantly, hiding from other friends and relatives and parents-in-law, the couple would come in and you did the procedure. They would not even tell their parents or anyone else in the family that they were going through the procedure. And when they had a baby, they would refer friends, but would not tell them that they had it through IVF. So it was such a struggle to, you can't, it's patient privacy is very important. You can't disclose anything that you have done for the patient. Then how do you sort of counsel the other lot? So that counseling part was difficult. There were myths around that's all unnatural. The babies will be abnormal. They'll be having cancer. You will have cancer because of the drugs. So many things. But, as information spread, I think here, information through print media, because social media wasn't there, but through print media, the interviews or the write-ups in print media, that also helped to improve a lot of awareness or create awareness. And then slowly it's like a domino effect.
Ma'am, you have established one of the earliest IVF centers in Delhi. State of the art clinics आपने शुरू किए हैं, और when you started all of those things, what was the biggest hurdle? Technology, awareness, ethics, or mindset of the people?
Apart from ethics, I would say everything else. At that time, thankfully, doctors had very good ethics. There are always outliers, and they'll always be there. But by and large, medicine was a totally different field, and there was a lot of respect of that field. You did the most difficult of cases, even though you knew that there would be repercussions or there would be a very high risk, but you did them because the patient trusted you and you did your best. So that atmosphere is unfortunately totally missing now. There is a distrust on both sides. The patient distrusts the doctor and the doctor distrusts the patient, and therefore does a million tests because you tomorrow he may be caught up in some litigation or the other. But I've enjoyed medicine always. Even today, if somebody said go back and work in Safdarjung, I'll work. I somehow enjoy I just enjoy working.
Ma'am, you've been strongly associated with ethical, evidence-based practice. As IVF becomes more commercialized today, what do you think young doctors should never compromise on, however bad the competition is? एक infertility specialist को क्या compromise नहीं करना चाहिए, चाहे कितना
ethics.
Ethics.
You should not compromise on ethics at all. And it's extremely, extremely disheartening because when corporates did come in, especially the IVF chains, you thought that perhaps now there'll be equity of treatment amongst the population and that the treatment levels would go up. There'd be better, you could, because financially there was financial support, so you could offer better things in terms of equipment, media, drugs, whatever, what have you, so many things perhaps you could offer much better. But it didn't turn out that way, unfortunately. And it's very sad and it's very disheartening that all of these chains and these corporates, the prime motive is, or the prime thought in their mind is finances. And we had during a conference, there was a panel discussion on what the corporates have brought into the ART world. And so they had invited me as well. I thought, very nice, let's see what the discussion is about. And there were about 10 of us there. And I was the seventh. So from number 1 to number 6, they only spoke of betas, of how to earn money, how their practices have doubled, how their money has doubled. No one even once spoke of, have they improved the treatment being offered to the patient? Not one person. And then I asked them, I said, why did you invite me here? I'm not a person for this, I'm not meant for this kind of a panel. But that's all. And it is so sad, because you would have thought that that's what would happen, because somebody's focused on a particular field of medicine. They have the money to provide for giving better, instruments in the lab, or providing a better lab. And then then the output becomes better. You have embryologists who are there, full-time embryologists who are there. So you can offer, everything improves when there is a supervision and a dedication to your work. Okay? But that was not the aim. In an IV, the least priority was the IVF lab, which is the heart of all of ART. If your lab isn't good enough, nothing is going to work.
None of your work will transpire into.
So that was one very sad part of the corporate structure that I have seen, which is very disheartening. And it is not only in IVF, it's across the board in all
the fields. Ma'am, I never knew the topic will go this way, but because I'm in a corporate hospital, and I've started my career in it as a budding gynecologist. How to get out of the circle, क्योंकि आजकल patient भी मैम corporate ही जा रहा है. मतलब it's not, जैसे आपने बोला, there is distrust both sides, है ना. I have the same ideology कि ठीक है, I mean, you earn money, but patients' care should be the prime priority. धोखा मत दो, इंसान अच्छे रहो. तो जब when I started off, I saw that, setting up a clinic, for example, in Delhi, is a task in itself. Nothing will be free on the platter. Everything will be in lakhs if you start giving rentals and all. So how to navigate this? Matlab, I know corporates are revenue driven. I personally, I am into a corporate which is not that revenue driven. I have not felt the pressure anytime. But matlab, as a doctor, how to navigate all this and, stand on your ethics?
No, you can stand on your ethics. There is nobody stopping you from standing on your ethics, okay? You never compromise with your ethics and or your work culture. And I think if all the doctors did that collectively, the corporates would have no choice. Okay, when you say patients only go to corporates, which is right, they do go to corporates. But how do they go to corporates? Because they are being sourced. They have, they advertise. They have people bringing in the patients with all kinds of whatever they do, I don't know. But that does occur, and not only in IVF and ART, it occurs across the board in surgical specialties, in every specialty. So if doctors collectively put their foot down, how can the corporates then do anything? They can't. But, it is that one individual who looks at his own interests and the money that he's bringing in, and then everybody starts falling into the trap. And I think, to my mind, that is the saddest part of all, because how can you compromise on management? How can you compromise on what you're offering the patient? You're offering the patient sometimes a procedure which they don't need, or perhaps a procedure which, is sort of totally wrong for them. I won't say totally wrong for them, but they could have done with something else.
Sure.
Perhaps it would be simpler, which would be cheaper, and which would sort of get them where they are. Or, you know, maybe it could be deferred for a time till you observed something and there was no need to be trigger happy and start off stuff. So all of that is not happening because of the pressures or because of personal things. I cannot say. I don't want to even comment on it, but I cannot be like that. Personally, there is no way that I can be like that, and that is why I do not now, I made one wrong move in my life, which was that I joined or I was asked to come and start off the Nova Center in Delhi. And but I brought my own ethics and my own work culture to it. And I must say that I am always grateful to Mr. Suresh Soni, who actually brought me in and asked me to join in. I think he ran that or had invested in that. He never refused me anything of what I asked and never forced me to do anything that was wrong, and always accepted what I told him. You know, and I think because of that, that particular unit became their flagship unit. Because we paid attention to where it was due, you know. We brought in, I told him embryology is one of the most important parts of this. So,
IVF.
you know, why should I join you if you're not going to focus there? So we had EV come in and train. They were here for a couple of years training the embryologists across all the centers.
Great, ma'am. So we know.
So you have to, if you put your foot down and you show that sincerity of purpose, your honesty and your dedication to work, people will accept that.
True. That's मेरे पापा भी हमेशा यही बोलते हैं. And I totally agree with you, ma'am. So actually, ma'am, in this podcast, the podcast series which I have come up with, there are many doctors of every specialty. And I have approached many and I have come to know them personally. मैं उन्हीं को बुलाती हूँ अगर मेरी बेटी या मैं खुद infertility की I mean I would have that issue, or tomorrow some orthopedic or some pediatric issue with my child or something, मैं उन्हीं लोगों को बुलाऊंगी whom I would consult. So that is the ideology I love about you, and that is why I thought कि आपको बात करनी चाहिए audience से. So
I tend to get a little passionate, so you should cut me down.
No, ma'am. That passion should come across, and audience should know, people should know the mindset certain doctors have, which is very important. कि अगर कोई, I mean, some doctor somewhere is deviating from track, maybe from seniors, they catch up on it and come on track. You never know.
So one message across to all the youngsters who are going into reproductive medicine is that they start calling themselves IVF specialists. You're not IVF specialists. You're here to, as reproductive endocrinologists or physicians who are dealing with reproduction
System.
Okay? IVF is so narrow. The spectrum of infertility is so wide, or reproductive medicine is so wide. And you want to narrow it down to that IVF. You know, maybe AI is just going to take it all over, and then what are you going to do? So that has to go. You're not an IVF specialist. You're somebody who's dealing with infertility. And you're dealing with couples who are, literally broken up emotionally by what they are undergoing. And you have to know how to handle that, and not just, give some medicines, take out the eggs, take out and put back the embryo. That's not what medicine is about. Medicine is about looking overall at the couple and going beyond that little procedure that you're going to do.
Abhi, I want to address all the patients, ma'am. Patients today are overwhelmed with Google searches, social media reels, conflicting advice from doctors. अगर कोई patient जाता है to a clinic for infertility. I don't want to tell now. Infertility IVF clinic. So if a patient wants to conceive and wants to go to such a clinic, what should the patient see in the doctor or that clinic or that corporate hospital beyond success rates? मतलब कैसे पहचाने एक patient कि मैं कौन सा doctor चुनूं?
I think this is the most difficult questions, and some question you ask me, and sometimes, when I sort of looking at a prescription and I tell the person, why did you go there? Because internally I know that that place is not really good. So they say, but doctor, how do we decide? And believe me, it's very difficult. I don't know. But a few things which may be pointers. One, that somebody who is not so, hell-bent on doing PR. They don't have their advertisements everywhere and minute to minute, and they're not saying that we have 85%, 95%, 100% success rates. Those are the clinics we should not touch with a barge pole, because that is not true. Whatever you may do in IVF, whatever, you don't go beyond 70%. You may go to, in a younger patient, to 80% or so, but you don't go 100%. So the people who are professing that, please avoid them like the plague. Try to go to a center where a senior, and when I mean a senior doctor, what I mean to say is doctors who came before this new lot of IVF specialists, older people, who are personally running and personally looking after the patient. So there are a lot of people who are in charge of a center. They really don't actively do anything. They set a protocol and the juniors follow the protocol. How can it be? If you're just following a set pattern, it can never be the same as a person who is personally looking after you. We talk so much about individualized medicine today, especially in ART. Everything individualized protocol, individualized this. What is individualization when you're handing somebody a protocol? That's not individualization at all. It's only when you're monitoring the patient very rigorously that so many things sometimes come up. Things you've done wrong, or you think you could have done much better had you done it some other way. But you'll never know it unless you're monitoring the patient.
You are in personal touch with the patient.
Ma'am, it's difficult. I mean, I'm not saying it's easy, but कुछ थोड़ा बहुत, especially जहाँ पे बहुत ज़्यादा promotion हो रहा है, where all these 100% results are being touted, those people you should not touch.
Ma'am, when you spoke about a team, I have a personal question which I wanted to ask you. You have a huge practice, ma'am. जैसे मैं आपको बता रही हूँ, I have a small patient base. I mean, जब patients आते हैं, and I have back-to-back patients, and I love, because many patients are having a lot of problems. उनकी emotional problems इतनी होती हैं. I want to sit with them, have a talk for quite some time, and मेरा मोटो रहता है कि जब OPD से patient निकले तो हंसता हुआ निकले. That is probably why I joined OBG, obstetrics and gynecology. तो होता क्या है मैम, जब ज़्यादा patients होते हैं, you can't give that much time to everybody, because everybody there in the waiting area is waiting कि कब ये निकलेगा और दूसरा patient आएगा. So when you interact with the patient and so many are waiting, how not to rely on a team, or जैसे आप बोल रहे थे ना, you have to be in personal touch with everybody. Any tips that you have, any suggestions how to tackle this problem?
I'm really sorry. I don't know what to tell you in this. For one, I don't have a huge practice. I have cut down my practice drastically. I work for half a day. But few things that I like to do. The first consultation, including the writing of the history, I do myself. Because many a time you elicit things which they may not tell your juniors. Okay? And and that sometimes can take 45 minutes. And I know patients are waiting outside, but I can't sort of not pay attention to that first visit, because that is what will tell me everything of how I have to plan my future management. And my future management is planned on that day. It's written on the side of the prescription that this is how we'll go forward. And that's told to the patient. Subsequently, in subsequent appointments, for instance, I like to do the ultrasounds myself, or at least see them myself, even if my junior is doing them. I like to stand there. Mostly I like to do it myself. I like doing ultrasounds. But it's like a window, okay? It's like a picture you have along with the clinical history or the presentation or the medication you're going. You can picturize what you're doing, what's happening inside the body when you have given this medicine or not given this medicine or withheld it. So that part I do. Subsequent to that, explaining the prescription or subsequent counseling, I let my juniors do that. I tell them, okay, this is what it is, and this is what you need to explain to the patient. And if they're not satisfied, they can come back to my room, but they'll have to wait. You know, but despite that, patients get upset. They feel that they have sort of not been given adequate time, or they weren't able to see me on that occasion or this occasion. But the problem is that you have to see everybody and you have to give everybody time.
Justified
and you can't just focus only on one person. I ensure that whatever treatment is given to them, that I'm on top of it. That even when they write a prescription, my juniors write a prescription, they come and clear it with me before they give it to the patient. But then I already know the background, so it's very easy for me to say, okay, yeah, go ahead, do that.
So, ma'am, you have handled some of the most difficult cases: recurrent IVF failures, recurrent pregnancy losses. How do you counsel the couple when time and emotions have run out, but medicine has the answer?
Well, I would like to correct that statement of yours. Many a time, medicine does not have the answer. And especially in this area where we talk about recurrent pregnancy losses and implantation failures, it's a whole gray zone where we have limited knowledge. There is far more to it than just that, because we know that when we do this, despite that, things happen. So obviously there is much more. There is the maternal immune system. There may be local immune factors. We really haven't got it cleared at all at this point. And a lot of that treatment is empirical. And you have to explain to that patient that, look, this is where we have a limit in science. And beyond that, we do empirical treatment. And you have to tell the patient this is empirical. This is not I can't guarantee you that with this, you're going to get pregnant. But this is what we have, and this is the way forward. And one thing which and I want to put it out there for the youngsters is that the moment a patient has one IUI failure or a couple of IUI failure, I'm not even talking about IVF, it's just the beginning of their management or their treatment, they are given such immune therapies which are still actually only in research. Very little we know about their outcomes. That is so debatable, so controversial. So you have already start giving that to somebody you have done nothing for. You have done an IUI, you have done nothing beyond that. And you start pushing them into these kind of immune treatments. And this is something which, time and again, we repeat it at every conference, but still I see prescriptions with the same thing going on. We had a patient who had undergone lit therapy, and then she had some emergency on which she had to have a blood transfusion. And they had such a problem getting her blood group right because of whatever treatments she had received, because it's from the paternal lymphocytes which are pushed in. Okay, so you have to think. If it were an answer, yes, that you're clear, 100% this is going to work, sure, work. But when you don't know, and it's such a controversial treatment, you have not gone through the whole step ladder of treatment, and you've gone from straight to Z before you've done anything else in the middle. So that is something which is not right. And perhaps another thing which through your channel, maybe it can affect some people, if not all, is that the moment they see a couple, the patient may have been married for a few months and suddenly or been trying for a few months, she's young, she comes to you, and bang, they go on to ovulation induction. Cycle after cycle after cycle. You have not given that woman a chance to get pregnant by herself without interfering with her hormones, without interfering with her endometrium, without interfering with her vascularity. You have just put her down on a
Pumped in.
path which she doesn't know where she is, because by the end of that 6 months when nothing has happened, she's just going to go into IVF.
True.
So it's not, reproduction is not McDonald's hamburger, 2 buns and something in between. It takes time. Even normal fecundity is 25%. It's not that a woman gets pregnant every month. So the important thing is, patients these days are the ones who want that McDonald's hamburger. Doctor may not want it, but the patients want it. But your job is to counsel them. And your job is to explain to them that if you go in for too much treatment too early, then at the end of it, you are going to land up in the IVF. That's it. There is nothing else left. We have only 2 treatments. We don't have much. So body has to have time. And if the person is young, she has a good ovarian reserve, what's the rush?
Ma'am, actually, I had some time back posted on my Instagram for infertility questions they wanted to ask me. One question kept repeating itself. It was कि अगर मेरा लो AMH है 0.3, 0.5 और and I'm already 33, 35 year old. I mean, this is not the complete history that we should be knowing, लेकिन ये बता रहे थे वो. If that is my profile and my follicular count is around 3, 4, how should I proceed? Should I go towards infertility or should I aim for a natural pregnancy?
First thing, you should tell her that social platform is not for this to handle this kind of a thing. No, people want to be treated on the telephone. It's not, because that person has to assess, is there a male factor there? If there's a male factor, she has no option but to go into IVF. Okay. If there is no male factor, the patient is extremely young, maybe she could have follicular monitoring and timed intercourse, or maybe a simple IUI. Okay. Because what they have to remember is that in IVF we need egg numbers.
Yes.
And where in a low AMH are you going to get egg numbers? Okay. And the lowest of AMHs, you will have pregnancy. AMH is not an indicator of pregnancy. It is only an indicator of ovarian reserve. The last patient who got pregnant, her AMH was, can you believe it? I'll take a guess what it would have been.
आप ऐसा बोल रहे हैं तो probably 0.1.
Exactly. Exactly. So that is not an indicator. So you have to evaluate the couple and see where it fits. And you have to make her understand that, people refer 0.3 mH, go and get your eggs frozen. What eggs are you going to get frozen? What are you going to get there? So you have to counsel that patient on how she has
Multiple
to go
parameters.
and what her expectations should be. And also reassure her that low AMH doesn't mean you're infertile.
Yeah. Usually I tell them, ma'am, that even if you have one egg, one good egg and one good sperm and it fertilizes, you'll have but you need to have a God's blessing. When you are coming to me, you are asking me risk-benefit ratio. So the probabilities I have to tell you. But yeah, I mean, low AMH does not mean that it cannot transpire into a natural pregnancy. But usually, ma'am, patients जो बोलते हैं ना कि मैम हमें ना इतना emotional turmoil नहीं चाहिए. We don't want ovulation inductions. Straight away, if we can afford, क्यों नहीं IVF करते हैं? There is that class of patients also.
No, that's fine. The only thing you have to tell them is, do not think. These are the patients who think if they're going to IVF, they're pregnant. And when they're not,
they are disheartened.
So dissatisfied and completely crushed, and you will be the person to blame because you took them through IVF. You have to explain to them that you can do it, no problem. But please remember that IVF is not a guarantee to pregnancy.
So according to you, ma'am, although I have a certain idea, आपके हिसाब से दिल्ली के best IVF centers में success rates क्या हैं?
You see, the cumulative pregnancy rates should be, like in our center, the cumulative pregnancy rates are around 70%. Okay, cumulative means, you have used up maybe 2 cycles. actually this is a one cycle thing, but overall this is what you should say. I don't think one should say that now 80% is my success rate, which is not true. Because when you go to 6 months or a year and you sort of then put the data together, you'll find it'll come back to that 60-70%. But if you're using genetically tested embryos, it can go up to 80%. But I would say somewhere between 60 and 70% is what it would be for all, most good centers.
So, ma'am, coming to fertility preservation, you're one of the strongest voices for fertility preservation in India and Asia. Why do you think fertility preservation is still underutilized in India, especially in cancer patients, non-cancer patients?
Believe me, it is utilized much more than what it was. Okay.
Of course.
So I had my first conference where I had invited Professor Myro from Israel. He is one of the pioneers in ovarian tissue cryopreservation, a very huge name. And we had a conference and I invited him because, again, after a while you want to do something more than what you're doing. And reading up on it and, listening to lectures, this really fascinated me. And I invited him here for a lecture. And then I went to Shiva to train. I took up a course there. I went. And after that, when I came back, trying to, knock on oncologists' door that you should refer patients, it was the toughest time. They just bang the door in your face and let the patient live before anything else. So I thought, this is, alone will not work. And so, a group of like-minded people joined and we formed a society and we printed information booklets. We went to places like Can Support, gave lectures. We went to oncology units and, requested them to join us for CMEs and all. So like that, we tried to, through information, and we created awareness, both in the public, in the cancer patients, as well as in the doctors. Doctors was more important. The first point of contact is always going to be the oncologist. Okay, so so slowly from there, it was very tough, very tough. 2014, we started, and today I'm so proud because everybody has worked so hard on this. We have such a huge, support now from the oncologists, and that they refer patients, and they're joining us in the society as well, and coming to our conferences and other things, and it's really, really fabulous what has happened. Of course, there's a lot more, and the biggest problem is financial, because it costs a lot of money. Everything is privately funded. There's nothing which is government supported, even though they promise you. When I had a conference here, Mr. Kejriwal had come in and he promised that they would do something, but of course nothing ever happened. But we need that kind of support,
So, ma'am, coming towards the closing segment, I want to touch upon something personal. हम दोनों Kashmiri Pandit community से हैं, and a community that is known has a deep respect for education, resilience, quite strength. How do you think that your cultural roots shaped you the way you are today, the achievements that you have got?
Completely. I mean, as well as I do, where education stands in our community. It is first.
Yes.
A person who has money or who's financially very, up there is not considered as high as somebody who has an education.
Is well read.
So that has, it has been so important in our lives. So it's sort of it's inbuilt. You can't get away from it. Then along with that comes dedication to service. So that is inbuilt. So if you have dedication to service, if you have empathy, if you have ethics, and if you have knowledge.
That comes from our cultural roots.
That comes from our cultural roots. And, I'm so proud that to see where the youngsters, Kashmiri youngsters, even though, we have faced genocide, we've faced such huge losses, our parents lost everything, everybody was thrown out into various places, but we've all stood our ground and come up. And I think it's all because education was always given so much importance.
Priority. So coming to my favorite section, ma'am, rapid fire. I did not include one question, but I'm going to ask you, ma'am.
Okay.
अगर आप गायनोकोलॉजिस्ट नहीं होते तो क्या होते?
Oops. I can't think of anything but medicine. It is my first love, but I would have loved to be a dancer.
अरे वाह मैम. मैम अभी आप बोल रहे थे दैट you don't do Instagram or any social media, but you like poetry. Any lines you want to
Oh no,
speak
please.
out? Arey ma'am, give it a try.
No, honestly, my memory is terrible.
Any poet that you really like? Any?
I like Rumi
Uh-huh.
very much, but I read everybody. I mean, there are
Any book recommendation from you?
no. Please don't ask me for all of that. That's tough.
One quality every good fertility specialist must have.
Empathy.
One IVF myth you wish would disappear.
That it's 100% success.
Any advice to a 30-year-old woman delaying pregnancy?
Don't. DONT with capital.
मैम फेमिनिस्ट जनता हमें नहीं छोड़ेगी. One advancement in ART that excites you the most today.
Regenerative medicine.
Your definition of success in fertility treatment.
The look you see on a couple's face, especially a mother's face when she comes in to show you her baby.
The baby.
It's incomparable. There is love, there's protection, there's joy, there's pride. It's a myriad of emotions.
Even after
There's nothing.
Even after so many deliveries, probably जब कोई patient deliver करता है, it still gives goosebumps. A habit that keeps you grounded despite such a demanding career.
As I told you, dancing.
Ma'am, it is very surprising. I would love to be a party to it and see you dance.
I'll show you.
One piece of advice you would give your younger self.
Take a break. I think I got so involved in my work. I just never took time to enjoy the things that I enjoy, and everything was about work, and responsibility and whatever. So take a break. Things will carry on, even if you're not there.
What is your heartfelt advice to young women doctors who are trying to balance a demanding career with a personal life? ये मेरा personal question है, ma'am.
So, don't neglect your family. Mm-hmm. Work will always be there. Patients will always remain. So, don't neglect your family. Try to, find a balance between the two. Because at the end of the day, if you have neglected your child, then you'll regret that for the rest of your life. The patients are never going to go away. They are going to be there. And one thing which I really sort of want to say, I know your rapid fire is ending, but I want to end it with this, that, what is the best validation that you can ever get of your work and of your whole life is when somebody says that they trust you blindly to give them the right advice. That has been my, best validation, the best compliment that anybody could ever give me.
I in my daily practice, ma'am, that is the only thing I want to be known for. कि जैसे मैम एक ना थोड़ी बचकानी बात है, जाकिर खान की ना एक लाइन है, काम कैसा भी हो लेकिन बंदा 20 होना चाहिए, 19-20 नहीं होना चाहिए, बंदा 20 होना चाहिए.
True, very true.
You should be, the core should be good.
You have to be honest to yourself and honest to the people you're treating. If there are shortcomings, you should admit them. That okay, this
and
I can't
there's
do.
Always scope
This I
of
can't
learning.
do. Please, go here or go there. This is the best place I can send you to. And people respect you for that. They respect you. I mean, I have patients coming back to me after 20, 30 years and telling me that, this is the advice I've been given. But if you say so, then I'll go because you're the only person I trust. So it means a lot. To me, that means much more than any money that I've earned over the years.
That is success for you.
That's success for me, yeah.
It was lovely having you, ma'am.
It was lovely being here, and I'm sorry if I get too passionate about things, but that's who I am, unfortunately.
It was my pleasure, ma'am. Knowing you personally and professionally, तो ma'am, you are the supreme. उसमें तो कोई दो राय नहीं है, but it was lovely knowing you.
Knowing you too.
Thank you, ma'am.
Thank you, Beta.